I have a 55-year-old male patient with CKD stage 2, would like recommendations besides Clotho and Retta for peptides to assist with safe visceral fat loss and mitochondrial optimization. So that's question number 1.
Yeah, a lot of these peptides are renally excreted. You do have to take into consideration dosing based on their serum creatinine and their GFR. I always like to check GFR and always keep that just keep that on your notes. Anyone less than 65, I'm careful about doing a GLP or even MADA-C or SS31, to be honest, because it is renally excreted also. I did see a dosing because it is FDA approved now, SS31 is for Zinity. They have some safety studies now with renal excretion. So anyone under like half than 65, they actually cut the dose in half with the SS31. Specifically. So I would say, I know besides Clotho and retatrutide, what would I recommend? Is that what it said? The question is for visceral fat loss. I would recommend maybe tesamorelin. It's great for visceral fat. That's what it's FDA approved for, actually. In HIV patients, I'd probably do 1 milligram Q day, 5 out of 7 nights. That combined with ipamorelin. I also like MOTS-C. I probably do a low dose, like 25 units or 25 milligrams twice a week, if not 3 times a week, and then optimize, of course, the cell membrane. I would go really low, go slow with these patients, especially if they have stage 2, which can be reversible depending on what caused it, So I like giving BPC and TB500. There's a good study that Joe did with a patient with stage 4, I believe it was, or stage 3, and he was able to reverse that and raise the GFR significantly with CJC. So I think that tesamorelin may be a good adjunct, but he did it with CJC, BPC, KPV, and that was back in December of 2019. I recall that study. We actually had Daniel Gasparo, his assistant, and his father, he extended his life by a few months, and it was amazing. It's a great study, and it's just us, right? We just do this together. We have one study.
We extended his life by 2 years, and his GFR went from 15 to 45. I just wanted to chime in there. I mean, it was very surprising how well he responded. But I had a question. So you mentioned Clotho and something about weight loss or treating kidney.
He said besides Clotho and retatrutide, what other peptides can help assist with safe visceral fat loss and mitochondrial oxidation?
But they have CKD. So they have CKD stage 2. And so that's why they were.
Okay. So Clotho, I don't know any therapies that are actually studied or even I trust as Clotho therapy. So I'm just curious what that.
Yeah. What kind of Clotho are you using?
Okay, wonderful. Yeah, because there's some MABs out there that they add albumin tail to the Clotho. We have no idea the pharmacokinetics of Clotho. We know baselines. We do labs on Clotho. We know the ranges of which Clotho as a baseline is actually protective in terms of developing disease and protecting the kidney. That's about 600 picograms per ml up to about 1,200 picograms. That it will stop renal insufficiency, the deterioration of the kidney, but maybe a little reversal. But the products or whoever has Clotho products out there, I don't recommend using them yet. We don't know if it's a pulsatile effect from Clotho or we need to maintain a higher level of sustained Clotho. And has a very short half-life like all amino acids. The last thing is above 1,700 picograms per ml, we see patients coming in with active cancer. So there's an upper limit of normal that keeps actually tightening up on the lab. The only lab that we use is Infinity Labs. That's the only lab in the country that actually measures Clotho, and I measure Clotho on all my patients. So we're down to about 1,700, and below that, because above that we see active cancer, and on the other end of the spectrum we see patients coming in with 0 to 0.1, 0.2 Clotho levels. So there is a sweet spot, kind of like Goldilocks, if you will. But I know certainly Clotho, when we get the right therapy out there, Clotho will have a significant impact on kidney function.
Yeah. And thank you for that, Dr. Joe. You guys just got to hear a little bit of Dr. Cleaver's brilliance. He is quite an expert in the field on Clotho especially. And he has already committed to bringing a specialty masterclass to Peptide University when it's ready. So that, as you just heard him allude to, there's still a lot of research that's being kind of filtered through. We are close. I think maybe before the summer's out, we'll be able to really have some verifiable data and understanding of things that we'll be able to confidently lead forward with, because everybody's buying it, right? And everybody's excited about it. And there are so many upsides to it that we're really hopeful for more to come. Dr. Warren had one more question before we move to the next. She asked, okay, also I have got a type 1 diabetic male, mid-20s, would like peptides to improve muscle mass and gym performance. Thoughts on that?
Muscle mass and gym performance, type 1 diabetic. Yeah, I'd still do the testosterone. I think it'll be fine, don't you think? And MOTS-C. Muscle mass, a lot of people like follistatin. I do like follistatin, but it does stay in the body for a while. So I just do it twice a week, if that, post-workout. I would just check liver function. That's a really good and effective peptide for muscle mass. I usually inject it right after a workout, like right into the muscle. It hurts like hell, but I don't know if you guys have ever tried it, but it's almost immediate. So a lot of bodybuilders do like that one.
And if you all follow Mary, you know that she is a bodybuilder, fitness competitor, so we can also, this isn't just she's giving us thoughts, like she actually really knows on the body composition side and really having like a really healthy physique. And so, we love your knowledge on that. But here's something I think is really important, Mary. One of the next questions coming in is really around glutathione. So now if we think about some of these molecules that we're looking at taking, and when we really think about the role of the liver, right? So some of us are using GLPs for non-alcoholic fatty liver disease. Some of us are using things that we're realizing like, wait, there could be a strain on the liver. Like the liver is that first pass through. And one of the master molecules, of course, is glutathione. So let's talk about glutathione for a moment. In the question that came up, it was specifically around dosing of glutathione to help lower LDL. But I'm also wanting to kind of dive into, for a few minutes, if you're comfortable with it, really help us to appreciate glutathione. Obviously, what's the benefit? Should we be looking at more precursors versus what are delivery systems of a straight like liposomal or a patch or something like that of glutathione? Because that's also like this question is, first, we got delivery issues. Where are we getting it from? Are we doing an IV, right? So let's dive into glutathione for a few moments, its role, its uses, how do we really account for it, and what can be some of the upsides of utilizing it?
Of course, I use it a lot in my practice. It's not bioavailable in the gut. You want to do a precursor, which is N-acetylcysteine, right? And which is actually used for acetaminophen toxicity, right? And acetylcysteine 10 and 20% in a nebulized form. The glutathione I use, I get it usually from Olympia, but you can get it from any compounding pharmacy. It's usually 200 milligrams per ml. And I have them inject a whole ml, 200 milligrams sub-Q daily for 4 months. So I'll check their LPPLA2 or LPPLA, which is, oxidative stress, LDL oxidation, protects mitochondrial function. So essentially, it's the mother of all antioxidants, right? So you're reducing oxidative stress, you're improving that liver pathway, and you're improving I will say my patients sleep better. So, and I can't make claims because it's not FDA approved, but yes, it does lower cholesterol. And I usually, it's a good, between first step is lower inflammation, lower the cholesterol if that's because I always check LDL, I check NMR if I need to as well, and then I start with hormones. Then I start with hormones optimization, but I always reduce that inflammation, manage the liver, and then start with hormones, because oftentimes if you're going to give something in hormones, they're in their liver, they're excreted or metabolized in the liver. Optimizing that I think initially is best, and then we can start on a GLP if they need it, but never start with GLP, right? So it's usually, start with managing that inflammation or what's causing it, the adrenals or gut. But sorry, alluding back to your question, I usually start with, if I'm going to lower cholesterol, an adjunct, you have to carefully note it on the chart that you're not treating, you're using it to support care. It's very important, but it's glutathione, 200 milligrams sub-Q daily for about 4 months. And you want to give them about a 4-month protocol. I don't give it to them all at one time. Each month I do have it sent to their house. And then I just give them syringes. Usually I do a 27 or 31 gauge, which is fine, 100 units, and then just inject it.
So Mary, let me ask you quickly. What are your thoughts? Do you have any data on delivery systems? So, in addition to like a sub-Q sent to house, what about IV versus there's even patch delivery forms? And there's also some brands out there that we know do a liposomal glutathione. So, what are your thoughts on the
Yeah,
different
yeah,
delivery
there
forms?
are I've talked to our, I forget his name, Dr. Patel. He's a pharmacist, fellow pharmacist
Hmm.
colleague.
Yep.
Well,
Yep.
I love him, and it increases NAD. I just I don't like the smell. It's quite pricey, honestly. Sorry about that. Anybody that uses them, and I haven't. I can't see my patients doing a pump every day. Do you know what I mean? Like, but they'll inject every day. Does that make sense? So for me, it's about compliance, and they're not gonna spray. Maybe a patch they'll put on if it's once or twice a week. You can do it in adjunct, but I'm always thinking about compliance.
Right.
And most often, yes, it burns, but they feel a difference, and it's great for recovery as well. A lot of our bodybuilders do like that also. It's not the only way, but for cholesterol, and that's like antiquated now. Like nowadays, with everyone, what is it, 1 in 5 people now on a GLP, it's rare that you're having someone come in for hypercholesterolemia, right? It's something that we just treat, but we are seeing, a reduction in LDL, significant reduction in LDL when you do glutathione for 4 months. You have to
Got
be
it.
consistent with it. So in terms of delivery systems, I would say the liposomal is okay. I do use it once in a while in the morning. I just don't have a lot of data with how that, and it goes into the plasma. So I would say it would work pretty well. I don't know if you do, if you wanted to chime in on that one.
I actually don't necessarily have the data. I mean, we do have a fantastic masterclass and interview with Dr. Patel,
Okay.
and just not necessarily about his product, right? But just about the molecule as a whole.
Yeah.
So if you're a newer member here, if you have not watched that replay, you really want to go deep into glutathione. I mean, it is one of the master molecules for a reason. And, when we really look at the effects from not just antioxidant, but when we look at what's happening in the liver, Mary, you just alluded to it. We always talk about upstream first. So
Okay.
before we go to add the BHRT, before we go to do a GLP or any advanced peptide therapy, there's so much that can happen upstream and so much has to filter through that liver, y'all. And that's where a lot of hormone conversion happens. Like it happens there. That's where we are detoxing. That's where we are converting from fat soluble to water soluble. What are we able to handle in our body? And so I do believe that there's just a really beautiful opportunity as clinicians to appreciate liver first. And I really thank you for saying that and just helping to kind of call that out tonight. All right, we got a couple of really amazing cases still left to cover before we wrap up tonight. We're going to see what we can do in 10 more minutes. I have a new client, 57-year-old male, who was diagnosed with MS 3 years ago. Other than a stable lesion on the spine, there have been no changes or symptoms. He's been stable with no active flares. He gets Ocrevus infusions 2 times a year with his neurologist. Are there any peptides you would recommend for support? Maybe thymosin alpha 1 or any peptides that I should avoid?
That's a tricky one. With autoimmune, you have to be very careful with probably LL37 is what I would avoid. Definitely. I think TA1 would be fine. PC would also be fine if he's only, but I wouldn't do it close to the time that he's having his dosage. If he's only having it twice a year, I'd probably wait a good 30 days before initiating any peptides, while it's still at its peak. The half-life is pretty long on that if it's just twice a year. And I would go low, go slow with his. I would start, I like, BPC. I think that would be okay. Depends on what you're treating. If he's not having any flares, there's really no need to start on anything. You kind of want to keep it there. Always put him on low dose naltrexone. I know I go low. I don't go up to 4.5. I probably stay at 1.5 to like maybe 3 milligrams max, depending on how he responds. But every single one of my MS patients or autoimmune are on low dose naltrexone and a low dose, and they just do maybe twice or 3 times a week of TA1. Less is always more in autoimmune patients, or really anyone. We really just need to sensitize the receptors. At the end of the day, it's really, it's about the receptors. So I hope that answers. Yeah, peptides I would avoid are definitely tesamorelin, definitely CJC. You can get anaphylaxis with CJC, NAD, 100% avoid. Anyone that doesn't check endotoxins. NAD sometimes can cause, I don't know if you guys have, it's not a peptide, but I would definitely avoid that peptide. I would just stay clean. Make sure you're getting 503A. So I would say TA1, and just avoid LL37, anything that's going to affect the immune system or maybe trigger an autoimmune response. And then just make sure you're putting them on low dose naltrexone. Start on probably 0.5 milligrams and then go up to maybe 3. Usually I start at 0.5 for about 7 days, then I go up to 1 for 7 days if no response, and then they're going to sleep so much better. So hopefully that helps. GA1 alternating.
Love that, Mary. Thank you. And I'm going to also add into that, Trisha, always think upstream. So in that, like, for what reason? We're always asking, what are the outcomes? So Mary just said, what are we treating? Based on our licensure, the type of practitioner, some of you are not treating anything, right? So, but what are the outcomes that we're looking to support or produce in this client or patient? And so I always come to think of, remember, and you guys, we are bringing out new education for you. So don't feel like you've missed something. So I'm just going to always give you context. First and foremost, what are the inputs coming into the system? So what's driving the system? How did we get here to begin with? It's great that they're stable. That's fantastic that there's been no progression. So that's really good. And so what are the current inputs? How do we get there to begin with, right? What's that internal terrain? So oftentimes when we think autoimmune, it's, I'll never forget this. One of my mentors really highlighted this forever ago. If we think of autoimmune, body attacking self, self-attacking self. And while this is a deep question, not everybody resonates with it because autoimmune has become so normalized, but really and truly, why is one part of me trying to attack or kill another part of me? Like, really, right? So if we get deep into the subconscious, emotional, I'm not asking you guys to do psychological work, but it is a very interesting place to look from. So all of a sudden, when things stabilize versus in autoimmunity, there's often flares. What flares the system? What's jacking up that system? What's overloading that system? So oftentimes when we are working with clients and patients that are autoimmune based, we're always defaulting to make sure that foundation is strong, because it's really, if we think about this, instead of that we're treating autoimmune, and what I love when we have the longevity conversation, when we look through the lens of longevity isn't about treating, it's how do we slow the rate and pace of biological aging. And so when we look through that lens, we start to have this conversation around resilience. Autoimmunity has lost resilience. So how do we bounce back? How do we take a hit? How do we hit the mat and get back up? Autoimmune has a flare, the whole system crashes. And that's why we're always taking biologics to try to keep it at a suboptimal so nothing stresses it enough that it crashes even worse. But what if we could build the floor, right? What if we can raise the base so that they become more adaptive, more responsive, hence concepts around hormesis and things like that. So there's foundational stuff, but I'm going to always push back and challenge you guys. Please don't default to just a molecule. Let's get even more intelligent in our approach as clinicians to appreciate what are the inputs coming in before we just default to a molecule. What, if anything, needs to be reduced and removed? Because it's what are the environments that they keep going back into? What keeps triggering and spurring that system to break down, or stabilize? Because in stabilization, allopathic care, we've been taught to stabilize and treat and manage a problem state. But what longevity and regenerative medicine is all about is we're not trying to manage a broken down state. We are looking to say, let's actually stabilize and repair and support that natural ability to create enhanced capacity, resilience, rejuvenation, regeneration. So if we stabilize, how do we get stronger? How do we get more resilient? And those are the things I would ask you to look at. And that's not always in a molecule. Mm-hmm. Now that's an autonomic nervous system. Maybe it's a Petersen, right? Maybe we need to stabilize that pineal gland. How are they sleeping? What are some of the HRV structures? What's happening with nervous system, vagal tone? So this now expands our toolbox in addition to just a molecule. Okay. And this is how we create practices that are reoccurring revenue models, because it's not just about a one-to-one and a one product. Don't sell peptides, sell programs, sell outcomes, sell models where there's resilience and healing long-term. Thank you for letting me have my soapbox. I apologize. This is a really good question. And Dr. Joe, if he's still on, might want to chime in on this one too.
Yeah.
I have a 46-year-old male with low testosterone, mid 500s, previously on TRT, but was told to stop, because of a newly diagnosed HPPF. sorry, I don't know that. HPPEF. What is that?
Is it heart
Is it
failure with preserved ejection fraction?
okay with severe LVH? Is there a contraindication to Wolverine protocol as an alternative to testosterone? That's not an alternative to testosterone, but go ahead, Mary, you take that.
Testosterone is contraindicated in heart failure. I mean, that's a simple answer.